Hey, it's Dr. Suchard again, with a clinical toxicology video discussion, this time about cardioactive steroids, corresponding to Chapter 61 in Goldfrank's Toxicologic Emergencies. The learning objectives are that once you've studied all the related course materials, you'll be able to identify at least two non-pharmaceutical sources of cardioactive steroids, be able to explain the biomolecular mechanisms of action of the cardioactive steroids, and outline the clinical effects seen with toxicity. Now, it's clear that the Goldfrank text prefers the term cardioactive steroids, but the traditional name for this class is cardiac glycosides, and that's certainly how I first learned it. I mention this mostly because I'm going to be using both terms interchangeably, and both are, technically, correct. Here we see the structure of digoxin, the only pharmaceutical member of this class currently in common use, although its use is on the gradual decline. With regard to digoxin being a cardiac glycoside, we see here the glycone portion consisting of three sugar moieties, and the rest of the molecule can be called the aglycone. And with respect to being a cardioactive steroid, we see that the aglycone portion of the molecule includes a steroid nucleus. This same structure is the basis for all steroid hormones and drugs, and the remaining portion is a lactone ring. Those cardioactive steroids coming from plants as their natural source have a 5-member lactone ring and are called cardenolides. Animal-derived cardiac glycosides have 6-member lactone rings and are called bufadienolides. Cardiac glycosides are found in several natural sources. Probably the most recognizable is the foxglove plant, Digitalis purpurea. This is a very beautiful flowering plant, but it's not the botanical source of digoxin as some may think. Instead, it's this close cousin, Digitalis lanata, that's the botanical source of digoxin. This plant has more dull brown flowers and is a lot less flashy. The illustration here makes it appear much more colorful and appealing than in reality. Lily of the Valley also has cardiac glycosides, as well as oleander. And I've already alluded to the fact that there are animal sources of bufadienolides, such as Bufo marinus, the cane toad. But all sorts of animals produce bufadienolides, including humans, and there are some medical conditions where these endogenous, digoxin-like immunoreactive substances play a role. The next few slides are going to show the mechanisms of cardioactive steroid pharmacology and toxicity. We're looking here at a cardiac myocyte. Depolarization occurs after the opening of fast sodium channels. The increase in intracellular potential opens voltage-dependent calcium channels, and the influx of calcium induces the massive release of calcium from the sarcoplasmic reticulum. In other words, there is calcium-induced calcium release by the action of the ryanodine receptor. And this calcium in the cytoplasm promotes the interaction of actin and myosin, producing muscular contraction. Then each cell needs to repolarize and reset. Repolarization begins with active expulsion of 3 sodium ions in exchange for 2 potassium ions through the action of sodium-potassium ATPase. This electrogenic 3 sodium for 2 potassium pump creates a sodium gradient used to expel calcium through a sodium-calcium antiporter. And the sarcoplasmic reticulum resequesters its calcium load through a separate ATPase, and the cytoplasmic calcium levels, which had just been elevated, fall back down to normal. Here we're going to see what happens at therapeutic doses of cardioactive steroids. Digoxin inhibits sodium-potassium ATPase. Consequently, the intracellular sodium is relatively higher because it's not being pumped out, and the extracellular potassium is a bit higher because it's not being pumped in. The relatively higher intracellular sodium content reduces the efficacy of the antiporter, expelling 1 calcium in exchange for 3 sodium. The net result is an elevated intracellular calcium. This extra calcium is pumped up into the sarcoplasmic reticulum, and when the next depolarization occurs, there is relatively more calcium released than normally, which allows the actin and myosin to interact more strongly than normal, and there is increased inotropy. This is how digoxin helps to treat heart failure by strengthening the force of each heartbeat. When there is cardioactive steroid toxicity, there's an exaggeration of the therapeutic effects that increase intracellular calcium. Excessive elevation of the intracellular calcium elevates the resting potential, slightly depolarizing the cells and making them more likely to reach a threshold to produce the next action potential. This is an increase in automaticity, that is, the likelihood of inducing another early or ectopic beat and predisposing to dysrhythmias. In addition to the myocardial effects just discussed, cardiac glycosides produce autonomic effects too. Just as the sodium-potassium ATPase inhibition causes myocardial cells to become relatively depolarized, it relatively depolarizes other cells too, including baroreceptor cells in the carotid sinus and aortic arch. This fools the baroreceptors into reacting the same way they would if there was systemic hypertension, and that signal of, "Oh my god, my blood pressure is too high," is sent up cranial nerves 9 and 10 to the vasomotor center of the brainstem. This results in increased parasympathetic tone being sent down the vagus nerve to the heart, which slows down the rate of action potential generation at the sinus node, resulting in bradycardia. The increased vagal tone also causes some AV nodal blockade, which would help to control rapid AFib by reducing the number of aberrant depolarizations that were conducted through to the ventricles. This is another potential therapeutic effect of cardiac glycosides in treating atrial fibrillation and congestive heart failure. With cardiac glycoside toxicity, we will often see bradycardia due to that vagal stimulation. But any number of cardiac arrhythmias might also occur, since there is also increased automaticity with AV block. The most classic cardiac arrhythmia is atrial tachycardia with variable AV block. The most pathognomonic arrhythmia with cardiac glycoside toxicity, although it is rarely seen, is bidirectional ventricular tachycardia. Other systemic effects include nausea and vomiting, abdominal pain, fatigue, weakness and confusion, and xanthopsia, a visual disturbance that we'll briefly return to in a later slide. Next, we're going to review a number of electrocardiographic findings with cardiac glycosides, both at therapeutic doses and with toxicity. Digoxin often produces a characteristic EKG finding called the digitalis effect, or just dig effect. On the top is a real EKG tracing with the dig effect, and on the bottom we see a stylized version of it, where the yellow circles are actually digoxin pills, deforming the EKG tracing to produce downsloping ST depressions, flattened inverted or biphasic T waves, and shortening the QT interval. The digitalis effect has a shape that has been compared to the mustache of Salvador Dali, the Spanish surrealist artist. It also looks like a reversed Nike swoosh. And on the topic of art and artists, we come to xanthopsia. Cardioactive steroid toxicity is associated with xanthopsia, a bias towards yellow vision or seeing yellow halos around objects. For instance, it's been theorized that Vincent van Gogh's choice of a color palette may have been influenced by his use of digitalis, which, at the time, was used to treat epilepsy. Virtually any arrhythmia can be seen with cardioactive steroid toxicity. Ectopic beats are the most common, but the most classic dig-toxic arrhythmia is paroxysmal atrial tachycardia with atrioventricular node blockade. In this rhythm strip, we see that the atria are going very fast as a result of increased automaticity, but not every beat gets through the AV node because of the AV nodal blockade. And here we see bidirectional ventricular tachycardia, which is virtually pathognomonic for cardioactive steroid toxicity. The QRS complexes are fast and wide, and they vary back and forth in shape with each beat since there are alternating ventricular pacemakers. Treatment of cardioactive steroid toxicity, like for nearly all poisonings, starts with symptomatic and general supportive care. With acute ingestions, and if the patient isn't having too much vomiting so they can tolerate it, you should consider GI decontamination with activated charcoal. And even relatively late charcoal administration may be useful since it will interrupt enterohepatic circulation. You should check and correct electrolyte levels as needed, with particular attention to potassium and magnesium, correction of which may reduce cardiac arrhythmias. There is an antidotal therapy with digoxin-specific antibody fragments. This antidote is covered in detail in a separate video you will probably want to watch next in this series. Other cardiac therapies include atropine for those patients with significant bradycardia, and phenytoin or lidocaine for those with ventricular tachydysrhythmias, whereas class 1A antiarrhythmics are contraindicated. An important consideration is the potassium level. We'd expect to see hyperkalemia with severe acute cardiac glycoside toxicity because we're preventing potassium being pumped from the extracellular fluid into the cells. In fact, hyperkalemia correlates pretty well with prognosis. However, If a patient has hyperkalemia from cardiac glycoside toxicity, you don't want to treat with calcium since the cells are already overloaded with calcium, as we've discussed already. There is the risk of inducing diastolic failure, where the heart muscle cells are stuck in maximal systole and can't relax well in diastole, a condition called a stone heart, which impairs cardiac filling. And if the heart doesn't fill, then it can't pump either. This is more of a theoretic complication than one that occurs commonly, but it would be good to avoid giving calcium to a patient whose problem is too much intracellular calcium already. And on that scary note, we've concluded our discussion of cardioactive steroid toxicity. I'll be seeing you around.